have three speakers. They will take about 8 minutes each, so we should have a bit of time for questions and comments afterwards. Our first speaker is Kevin Skerrett, a Senior Research Officer and Pension Specialist at CUPE. He's also a member of the Ottawa Health Coalition and is a visiting professor in political economy at Carleton, where I was a quarter century ago. So without further ado, Kevin.
Thank you very much, Hugh. I'm going to assume everybody can hear me okay, unless I see signals otherwise. Thank you very much for the introduction to Sala and the organizers of the event. It's a real honor to be a part of this. And let me just add a couple of things. I'm going to look at my notes. Just to introduce myself a little bit further, I just want to add the detail. I am a CUPE researcher on pensions, which is, as I'll explain, why I'm so interested in some of what's happening. But just to say, I'm officially, if anything, I'm officially representing the Ottawa Health Coalition and not CUPE, although I think a lot of what I have to say today will reflect a lot of the concerns and perspectives of CUPE, but I'm just not officially here in that capacity. I would just say as well that I think one of the other reasons that I've been invited is I've done some recent writing and research on specifically one of the for-profit long-term care providers in Canada, Revera, including an article that was recently published which was called Pension Fund Capitalism and COVID-19, the Case of Revera. So if you're interested, I won't be able to cover what I put in that article, but if you're interested in Revera in particular, which I'm going to talk about, I'd encourage you to have a look at that. Even if you just Google my name and Revera, I just checked, that's what comes up. What I'm going to do, I only have 8 minutes, probably 7 now, so I'm just going to try to cut to the chase on a few simple topics. One of them is just a check-in on who owns long-term care provision in Ontario and a little bit in Canada. Secondly, and the real crux, why is it that one of Canada's major pension funds is the ultimate owner of Revera? How did that happen, and what is that structure? And then the last piece, and really the most important piece that I'm sure all of you who are tuning in are going to be most interested to think and talk about is, what can we do about this? This makes Revera a different category from some of the usual suspects that we talk about, Chartwell and Extended Care and Sienna and so forth. And I have a few thoughts. Some work is underway already with a kind of a campaign that we've called Make Revera Public, and I'm going to talk a bit about that, but then talk as well about what else we might do, what people who are concerned about this situation might do, and so forth. Okay, so that's my agenda. Let me just start with a few quick words just about ownership. Again, I can do this quickly because I'm guessing you all have a sense of this. The Ontario Health Coalition publishes material on this regularly. Ownership of long-term care provision in Ontario and in Canada is a mixed picture, although in Ontario it is, I think, the jurisdiction with the most for-profit providers and beds and facilities. I think Natalie told me that if we were able to trace in detail over the last 30 years from the 90s to today, the picture has moved from something in the range of 40% of beds in Ontario were operated by for-profit providers, and today it is something more like 60. So it has been a process of more and more for-profit provision, but of course there is also not-for-profit provision and public. There are municipal homes, publicly owned homes in Ontario as in other jurisdictions. The relevance of this in the context of the pandemic and COVID-19, quite obviously, I think we all know, as of May and June, data started to get published by the Toronto Star and various researchers, including the Ontario Health Coalition, showing that the record of death rates, frankly, right to the most brutal of the statistics, the death rates in the homes that were operated on a for-profit basis were showing as 4 times higher than the public homes. And this is important, partly because of the extent of the provision, but also because for researchers, including Hugh Armstrong and I'm sure others with us this morning, this should not be a surprise. The problems and the gaps in management and structure and process between private for-profit and public provision were already known, including higher death rates. So I'm just going to provide one little citation from a recent publication actually published by Pat Armstrong and other researchers in the Skerrit collaboration that Pat Armstrong oversees. One of their conclusions, just to put this in a nutshell, was as follows. Private for-profit services are necessarily more fragmented, more prone to closure, and focused on making a profit. The research demonstrates that homes run, long-term care homes run on a for-profit basis, tend to have lower staffing levels, more verified complaints, more transfers to hospitals, higher rates of both ulcers and morbidity. Moreover, managerial practices taken from the business sector are designed for just enough labor and for making a profit rather than for providing good care. Another point that's made, I don't have the citation, but another point that's made in this same research piece is that the effect of that difference actually has a drag effect on the provision in the public, in the not-for-profit and the public facilities, meaning that there is a negative a load, a heavy drag that's imposed on public operators on all counts when it comes to compensation and wages of the workforce, when it comes to care provision, standards, and so forth. So this presence of for-profit provision, I think we all agree, is a serious problem. And that is why, of course, the Ontario Health Coalition has made this such a priority to try to really just use, seize this opportunity of the pandemic to recognize Ontario and Canada took a wrong turn many years ago in allowing this part of the healthcare system to be so privatized. The pandemic has exposed in dramatic and tragic form just how serious that mismanagement and terrible policy has been. And so what do we do about it? We've got to find a way to transition to a public ownership and management and democratically accountable model. So that's the point, but let me move to Revera specifically. Revera, because this is kind of, what I bring to this is a bit of knowledge about what Revera is. So what is Revera? Revera is the second largest provider of long-term care in Ontario and according to the measures I've seen, also in Canada. So in terms of size, number of beds, number of facilities. Now, as I said, very strangely, Revera is owned by PSP Investments, which is a federal crown corporation responsible for investing federal government pension funds. That was established, PSP was established in 1999. It acquired a chain of private for-profit homes in Ontario in 2006. And it has owned and operated, it consolidated that chain under this new name, Revera, and it has owned and operated Revera under that name ever since. And in fact, it has grown, it has divisions in the United States, it has divisions in the United Kingdom. It's actually a very large company, multi-billion-dollar company. And the point I want to cut to, and now zero in on, just for strategic action purposes, is PSP is not an investor in Revera. PSP owns Revera outright. It doesn't own a few shares. It doesn't own 20, 30% of the shares. Revera is a 100% owned subsidiary company of PSP Investments. And just to underline, PSP Investments is a 100% government-owned federal crown corporation overseen by the federal cabinet. So I'm underlining this point because I think, we are all very focused on the provincial jurisdiction, provincial government, provincial policy. This actually puts the crisis in long-term care and the for-profit provision of long-term care onto the agenda and the table of cabinet, of the federal cabinet, which I think invites discussion about action. I'm just going to check with Shala. Have I still got a minute? Yeah, I still got a minute. So this is clearly very important. And I just want to say very quickly in the last minute or so that I have, that the fact that Revera is owned by a federal crown invites obvious action. And in fact, in a sense, the good news here is that there has already been, in the last several months, some really important action steps taken. First and foremost, what really caught my attention as a pension researcher is in late May 26th, the Public Service Alliance of Canada, or PSAC, which is the trade union representing the largest single number of federal public service workers whose pension plan is managed by PSP, came out with a statement, a public statement, really just condemning the fact that their pension fund is owning Revera, which has, clearly all of these problems, facing class action lawsuits, and really they take the view that healthcare should be public, there shouldn't be a private company, and there definitely shouldn't be a private for-profit company owning long-term care that is owned by their pension fund. And the important key here, they came out and they actually called on PSP and the federal government, if necessary, to enact a transfer of ownership, not just a divestment and a sale, but a transfer of ownership of Revera into public hands, into public ownership, on the principle that it should be publicly owned and managed. And just to cut to the chase here, Ottawa Health Coalition was very enthusiastic. We're based in Ottawa, a lot of federal public service workers in Ottawa. We organized a town hall meeting about this called Make Revera Public in mid-September. We had 300 people tune in to that town hall meeting. And we've had, one of the little action steps that were taken there was a little online letter to federal ministers calling, supporting the PSAC call and calling for Revera to be made public. Latest I heard, 3,000 letters or emails, online emails, were sent to cabinet ministers about this, even just in the last number of weeks since that town hall. And then most exciting, and I'll finish with this, most exciting, just in the last 2 weeks, I think it was 2 weeks ago, finally, another trade union representing PSP-affiliated pension plan members, and that's PIPS, the Professional Institute of the Public Service, the second largest union representing federal government employees, issued a statement saying that they have also communicated with Cabinet, calling for government and PSP to enact a transfer of ownership of Revera into public hands. So as far as I can see from their statement, they've joined the PSAC in making this call. So I wanted to make this the centerpiece of my comments today to say, I think this is maybe just the beginning of a whole other track of potential action on making this real centerpiece for-profit provider into a publicly owned and managed provision. I think there's real opportunity here to make this part of continuing strategic action. I have some further thoughts on how we might think about doing that, but I'm going to cut myself off and turn it back over to the chair. Maybe we can get into action ideas in the Q&A.
Very good. Thank you very much, Kevin. One of the things he didn't say is that he is the co-editor of a book called The Contradictions of Pension Fund Capitalism, published by Cornell University Press a couple of years ago. And the contradictions, I think, are particularly apparent when it is workers who own this private sector company. So I will turn it over to Sala now, who is going to introduce the presentation by Shalom Schachter. He can't be with us today, but he has recorded his presentation. He is a rabbi, he is a lawyer, he's a member of the Interfaith Social Assistance Reform Coalition and very active in the Ontario Health Coalition. So Salah, I turn it over to you.
Okay, perfect. I'll be playing a video now, so I will be sharing my screen. Just taking a second. And just to preface it,
residents of long-term care homes and the care that they receive. Historically, we've known that for-profit long-term care homes provide fewer hours of care to residents than are provided by not-for-profits and municipals. So when COVID-19 started and it had a significant impact on the residents of long-term care homes, we wanted to see if there was a difference in the impact on residents depending upon the type of home. We did an analysis through the Ontario Health Coalition. It was the first one to look at type of home and death rate. Subsequently, other research and media entities took this up. But in our first effort, it did demonstrate what we suspected. We looked at the reports of deaths in homes. We went to the ministry website to properly identify the type of home, whether it was for-profit, not-for-profit, or municipal. We looked at their website for the number of beds, and then we calculated and identified ratios of deaths per number of bed, and it demonstrated what we suspected, that there was a higher death rate in the homes that are owned by for-profits as opposed to ones that are not-for-profit or municipal. The chains, Revera, Extendicare, and others argued that it wasn't a question of the status of the owner, but really the size of the facility, and claimed that the smaller homes, the ones with more wards with 4 residents per room, were more owned by the for-profits, and that's why they had the higher death rate, and it had nothing to do with type of ownership. But basically what they were implying is that they were unwilling to upgrade their own facilities. They have the money, and there is government funding to renovate and rebuild. They could have done this with the funding they already had, but they were trying to extract greater monies from the government before they were willing to do the upgrade, and so they have to share the responsibility for the higher death rate. What happens when beds are awarded or there is redevelopment? The government does provide a fair amount of financing, and these are grants to the companies. When they sell the facilities, they don't have to repay the money that they got from the government. They get to keep all of the profits that were based on the government initial investment. It's not that they don't have the money now, because they continue to pay out millions of dollars in dividends and executive compensation. So what we have is chains that are unwilling to upgrade, that are unwilling to increase their staffing ratios. We also know that there's been rationing and inadequacy of personal protective equipment. This is responsibility of the chains, but it's also a responsibility of the government. The government recently said that they are not going to be solving the homes problems, that it's up to the homes to solve their problems on their own. This contrasts with British Columbia and Quebec, who early on at the time of the first wave hired, created lots of new PSW positions. Ontario has only recently created 2,000 positions. Quebec, on the other hand, that has a lower population, fewer long-term care beds, created 10,000 new PSW positions, paid for the training, paid the trainees while they were receiving training, guaranteed them full-time hours, and a starting hourly rate of $26 plus benefits. This is much better treatment than received by staff in Ontario. We had the $4 federally funded supplement. Now it's just a $3. It's only temporary and there's no mandate to make positions full-time. They're also still, they're not allowing part-time workers to work in more than one home, and they're not mandating that these workers should be offered full-time positions in a single home, but they are still allowing agency staff to be used, and these agency staff go from one home to the other, and so they're creating the very transmission of infection that was intended to be prevented by limiting part-time employees to just one home. Why would employees want to work in the for-profits when they can make a higher salary in the municipal homes? Work in long-term care, like other healthcare work, is primarily female dominated, and we haven't valued the work of women in the workplace. In the 1980s, the governments were forced to recognize that they had a role to play in correcting this inequity, and so they brought in pay equity legislation. It didn't really work initially for smaller facilities without male comparators. And so the NDP government in the earlier 1990s brought in proxy pay equity, which identified larger entities doing similar work that had male comparators. And so for long-term care homes, the for-profit homes, the proxy comparator was municipal homes that did have male comparators and paid more. And so the proxy employer for-profits was the municipals. When the new government, the conservative government came in, they ended proxy pay equity, and therefore we haven't been able to maintain a proper comparison for conditions of employment between employees of for-profits and those of the municipals. And that's one of the reasons why the conditions of work in for-profits, especially in terms of compensation, is less than in the municipal homes. Residents are still left with inadequate numbers of staff because staff are not willing to make themselves available for these poor working conditions. We have yet to have a proper understanding that improved conditions of work lead to improved conditions of care. Lastly, those workers that are unionized need to be more aggressive with arbitrators. Arbitrators are very conservative, very reluctant to make major changes, just tinker around the margins. And arbitrators share a responsibility now that we know the truth of long-term care homes revealed through pay equity, through COVID-19, to have to make major improvements in conditions of work and otherwise share the responsibility for what's happening to the residents through poor conditions of care that are mandated by the employers.
Thank you, Shalom. I will mention a couple things here. One is the contrast between what's going on in Ontario and what's going on in BC and Quebec in particular. It's a contrast that puts Ontario in a particularly bad light, except on pay equity, where Ontario has traditionally been a leader. The current government doesn't promote that much, but it's good to be reminded that most of the workers, almost all of the workers, are female, and also to be reminded that the conditions of work are the conditions of care. With that, I will now turn to Shelley Smith, who is our third panelist. We're probably not going to have much time for questions and comments, but please submit them anyway, and it is hoped that you will get responses later on. And of course, you can read the comments of everybody else who has joined us in this important session. So now, Shelley Smith, a passionate advocate for PSWs, herself a PSW for more than a decade, and on the executive of Unifor Local 2458. Shelley.
Good morning, everyone. Yes, my name is Shelley Smith. I'm currently second vice president of Local Unifor 2458. Yeah, I'm also a PSW. I worked for a nonprofit employer, one of them being Revera, for many years before Revera sold off the long-term care home to a different for-profit owner again. The topics and the issues of working conditions in long-term care are not new issues. They're issues that have been in the media on the forefront for years, many years. As a worker in a long-term care facility, my union had given me platforms to talk about conditions that were happening in long-term care. We've lobbied governments, we've had campaigns, we've had reports put out by the Ontario Health Coalition advocating for change for workers and residents in long-term care. And nothing's been done in all these years, and now with this pandemic, it's only made issues worse. Just to name off a few of the campaigns over the years that we've done as a union and the Health Coalition. I mean, there was the most current was a video that Unifor, QP, and SEIU put out. It was a very powerful video showing residents throughout the periods through COVID, and then at the end of it, they died and they went out in a body bag. It was very emotional. It was very powerful, and the video was again to end care for profit. There's been several dignity for respect in long-term care, improving staffing standards in long-term care. There was a 6-minute challenge so people could understand that a PSW has approximately 6 minutes in the morning to get a resident up and prepared for the day. That's showered, that's whatever we do in the morning, that's the approximate time that a PSW has to prepare the resident in the morning. Jerry Diaz, our Unifor president, challenged Doug Ford to work a day in a facility with them, and of course Doug Ford hasn't accepted that challenge yet. And then the current campaign again, which is Care Not for Profit. The Ontario Health Coalition, Natalie Marin, Tracy Ramsey, and everyone involved in fighting this battle as well with us, put out very detailed reports, situation critical, which is just that, outlining how serious and how critical the situation was in long-term care. Caring in Crisis, the PSW shortage report. We've had roundtable discussions throughout Ontario with local politicians, with owner-operators, workers of all classifications of the home, management, discussing the problems in long-term care. Shortage of staff, not enough full-time work available, better working conditions, wages, benefits, just to name a few. And employers have done nothing with this information, absolutely nothing. Now we have a private members bill, Bill 13, a Time to Care Act, calling for 4 hours of direct nursing care. And this bill is so important, and it really needs to be supported and hopefully passed, because this would ensure that PSWs are allowed time to give proper care to residents at an appropriate pace for each resident. And to allow them some independence. And what I mean by that is, I'll give you a bit of an example. So right now, staff are working so critically short that walking a resident to the washroom versus just changing the resident. So, you know, some may think this is horrible, but you know, because we do this every day and we take it somewhat for granted, but in a long-term care home, walking a resident in these conditions now, walking a resident to a toilet, to the washroom, allowing them the time to set, maintaining a closeness so that, and giving them privacy so that you're ensuring that they're safe while they're on the in the washroom. Then you provide the pericare. Then you would walk them back to their chairs. That could take up to 20 minutes and longer. And time doesn't allow them to provide that small level of care to a resident. So it's easier, less time just to change that resident. The care of the residents is delayed. PSWs are not able to get to residents in a timely fashion. And that's problematic as well, because then residents may exhibit expressions. An expression is a term used to describe the violent act of a resident on a PSW or to another resident. And PSWs are made to feel at fault, but this is not the fault of them. This is the for-profit owners and the government failing to address the PSW shortage and before it reached this crisis, and now we're adding a pandemic to it, which is now like just a colossal problem. It's a big, major problem. The assumption and the accusation that PSWs are uncaring and lazy, problematic, unwarranted, it's just the opposite. PSWs want nothing more but to provide the very best of care to their residents and because the residents are their families. And some residents, that's the only family they have. I had a resident that he did have a sister, but over the period of time, he lost his sister and he had no one. He passed away, and I was the only one that attended his funeral. Excuse me, I was the only one along with my niece that attended his funeral. And then the caretakers at the funeral home asked us if we were going to go out to the grave site, and I mean, you just weep, because how do you die and have nobody? Nobody's there with you, nobody. So of course we went out to the grave site, but I mean, this is what PSWs do. This is what PSWs go that extra mile to do. This is how they work. Even working short now, which in some of them is considered a new norm for them. They prepare themselves knowing that they're going in short. They don't know how long, how short they are, of course, until they get inside. And some of them are in their cars crying before they go to work, I guess, to lessen the anxiety and the stress. And some of them are telling themselves, you know, it's going to be okay. It's a good day. I can do this. But they deal with what they have, and they make the best of what they have. But the government calls them heroes. I've never seen a hero be treated like this. They come to work, they're full of anxiety. They now only could be the only provider for the family through this pandemic. They have a fear of catching the virus and infecting their families, burnout. And for those who worked in COVID outbreak homes, PSWs lived in trailers in the parking lots of the long-term care facilities, and they were away from their families for months and were working ridiculous hours because the conditions were bad and there was no one. There was no one to work. They're left with decisions of making the decisions of the care of the residents, how it's going to be provided based on the time and the shortage. They work through their breaks, they work through their lunch to provide the residents with the best care possible. And there's always a fear that if they don't complete all of the tasks, they will be disciplined for it. They're broken. They're left broken now. Like they're broken. They're the most selfless, compassionate, loving, resilient people that you will ever meet, and will go out of their way for residents. And during COVID, through COVID, they're not left with a lot of vacation time off, because the government order said, I don't have to give you, the employers don't have to give them time off. So that time is essential for their mental health. And, you know, it's leaving them calling me and asking me why their life is not valued. Why are they not valued? They worked through conditions that I just don't understand how it's allowed for this amount of time. They homes, I don't understand how these for-profit owners were not prepared for this pandemic. They have to do a mass fit test one or two every 2 years on the employees, and they have to provide the ministry with a pandemic plan. So how is it that there wasn't enough personal protective equipment in the homes? The homes should have had an abundance of this equipment. What's the point of preparing a pandemic plan if it's not to make sure that when the day comes, the home is ready and equipped to deal with the pandemic? Residents and staff have lost their lives because of this, and there's a total lack of accountability on the for-profit owner. They didn't have enough PEE, or they just didn't have it, which is shameful because it should have never been. PSWs would, inquire in the very beginning of the outbreak. They would ask if they could just wear a mask to work, I guess as a preventative and precaution for themselves, and they felt okay. But it wasn't allowed because at that time, public health said they didn't need to wear a mask, so the home wouldn't allow them to wear a mask. But then when the COVID started hitting long-term care, I think it's a little bit late now to say, okay, we should wear a mask. It was a little late, because many workers and many residents lost their lives. Isolation and caring for COVID patients. Isolation is to be set up outside of a room. You're supposed to have gowns, masks, goggles, gloves, a bag for disposing. And PSWs are to gown up. They're to go in and care for that resident that's inflicted with the COVID. Then they're to disrobe, gown up, and go to the next resident. You don't get one gown, one mask for one room and you change 3 people in it. You're to prevent the spread of the disease, not spread it. So the for-profit owners have to be made accountable for this. They have to be made accountable for the loss of lives because they were not prepared. And if they were prepared, there could have been a possible prevention, or there could have been lower numbers. The fight is still continues for PSW working conditions to improve in this sector and to try to attract them into this sector. And pre-COVID and through the pandemic, employers have had ample opportunities to try to resolve or to improve something, and they have done nothing. And now in this pandemic situation, it's just out of control. For example, on a midnight shift in one of the homes where they have 2 dementia units and 10 care floors, PSWs, when they have total complement there's 14 on a midnight. This is a midnight shift, so there's 14 on a midnight shift. So there's 2 on each dementia unit, and then there's 1 on each of the care areas, and then 4 of them would float between the 8 floors. So when they go to work today, they're working with 1 on every floor, 10 PSWs in total, 1 on every floor, 2 to float between 4 units. And the problem is that on a dementia unit, there's a bit of there's a safety risk
Shelley,
there. So to have
Shelley,
1 person there is pardon?
Shelley, the problem we have is that we don't have any time.
Oh no.
You could
I
go
have
on
so many more.
sure. And it's been much appreciated.
Can I just make one closing statement?
One very quick final comment, please.
Okay. So I just wanted to say that once we're through the pandemic and the government has given PSWs a $3 premium, they haven't given it to everybody, but they've given it to the PSWs. Once this pandemic is ended, this is not going to be any better. The mental health is going to be on the rise. Every flu season resident, or there's going to be a potential drop in staff. The post-traumatic stress that staff are feeling, and the freedom now that the for-profit owners are just given another free pass to have absolutely no accountability when profit over care, for profit over people, is more important than the care of the people. So the owners have to be accountable, and we have to end care for profit.
Absolutely. Thank you very much, Shelley. Very powerful statement. And what struck me was that it was both direct in terms of what an individual PSW is required to do and prevented from doing day by day, hour by hour, minute by minute, on the one hand, and on the other hand, drawing attention to the structural issues that are involved, that we don't yet have the 4 hours of direct care per resident per day. And that 4-hour thing, by the way, was devised by researchers 20 years ago when acuity levels were much lower than they are now. And yet we still don't get to the 4 hours per day. The commission that the government set up does say that we should move towards that 4-hour thing. So that we're making a little bit of progress, but as Shelley has just reminded us, we're in it for the long haul. We have only about 5 minutes for comments. If you open up your chat box, you'll see that there are a lot of them already. And of course, you can have a look at those comments and add your own after we're through here. Kevin has already answered some of them. So I wonder if there are any other very brief comments that people would like to add on the chat device. It's at the bottom of your screen. If you jiggle it a bit, you'll see chat. So please add your comments. And Kevin and Shelley, have you any final observations you'd like to make in about 1 minute each?
Okay, David.
I will just offer less than 60 seconds. I put in the chat encouragement for people to check out our online action letter, and there's a web link for that. At the very minimum, everyone could click on that. It takes about 1 or 2 minutes to sign that. And I'll also just add, as people may have seen, if you haven't yet, please read the Ontario Health Coalition's commentary on Bill 218. This is new legislation from this week that has literally extended a kind of legal immunity to the for-profit long-term care homes that will, in effect, legalize their negligence that led to death, retroactive to mid-March. So the whole time of the pandemic. This is a unconscionable piece of legislation. I'm sure the for-profit companies are thrilled by it, including Revera. But this, we need to, or we can't possibly allow legislation like this to pass.
Thank you very much, Kevin. We do have privatization by stealth and also privatization out in the open. We have them both. Shelley, any final comments from you?
Just to kind of piggyback off of what Kevin has said, like that cannot pass. The owner would totally not be accountable for anything going forward. It would open the door, I believe, for them to be able to, well, the order says they could bring volunteers or unqualified people into the retirement and long-term care homes. And now with this new taking the total responsibility off them, what's going to stop them? They've been given a free pass, technically, to do what they choose to do with no repercussions or no accountability. Like it's going from a bad situation to a worse situation, and caught in the middle of it is the workers and the residents, and they don't deserve this. They deserve to be able to go to work and provide the best care in a timely fashion to these residents, and be able to set and even just be a companion to that resident that needs that stroke or that reassurance that everything's going to be okay. We have to end this. We have to end the care for profit, and we have to find and improvements, and the improvements need to come not tomorrow, but they need to, well, they should have come tomorrow, because it can't go on any longer. This cannot go any longer. And I'm sorry, I'm a rambler. I apologize.
We're certainly in it for the long haul.
I am. We're in it for the long haul.
As Shalom reminded us, the conditions of work are the conditions of care. And the conditions of work are appreciably worse in the for-profit sector, and within the for-profit sector, appreciably worse in the big chains. There are 5 or 6 or 7 of them. And so we're in it for the long haul. Thank you to our speakers, directly to Kevin and Shelley, indirectly to Shalom, who I'm sure will find out about this a little bit later.